So when we can start now.
So good evening, doctors. I Shuman on behalf of Shield Healthcare, welcoming you all. And today's another session with Dr. Samstuti Patanaik Madam on recent advances in PCOS. And it's my honor to introduce Madam. Madam is a consultant obstetrician and gynecologist, a laparoscopic surgeon and infertility specialist, Shanti Memorial Hospital, Rourkela, Odisha. Madam did her MBBS from Utkal and MS in OBG from RGUHS. Madam did her fellow in minimal access surgery from Belgium, fellow in reproductive medicine from Germany, and fellow in fetal medicine. So with the short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Sheet Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you, Madam, and over to you, Madam.
I would really like to thank Shield and everyone for giving me this opportunity to speak on a topic which is, I think, a very, very important topic for all the OBGYN people, that is PCOS, and to know what are the recent advances, it's very, very important. Because I think we are dealing with this huge, I would rather say it's another pandemic among women in the entire world, that is polycystic ovaries. And I find the incidence increasing every day in the OPD or elsewhere with among family and friends and all that. So it's really disheartening that it's coming out in such large numbers. But then we have to definitely fight with what evolution our generation is having with the lifestyle change and all that. So everything has its pros and cons. Every generation has its own problems. So I think we have to fight it out in a good way. So let's see what we have for the recent advances. Yeah, so coming to PCOS, as you all know, it's not merely a reproductive disorder, but an endocrinological disorder affecting women in their reproductive years. So it is a composition of many factors. It is not just confined to pregnancy or conception or anything. It is a huge hormonal milieu of many things. So it is mostly medical, endocrinological, gynecological, a mixture of so many disciplines, which a multidisciplinary approach is that's why called for when it comes to PCOS. Although hyperandrogenism and infertility are there, PCOS causes are distressing to young women. Its metabolic sequelae eventually plague the individual in terms of morbidity and mortality. It is crucial to diagnose PCOS as early as possible in its course, because the course of it, the sequelae of it, it's definitely going to affect the woman in different age groups. So it is very, very important as early as the diagnosis is, even from the adolescent age group. It is imperative not only to recognize it, but also to delay or arrest its metabolic sequelae. Additionally, screening for the expected complications may allow for proper and timely management of these conditions. We all know that, and that is the reason why we are discussing so much about PCOS every now and then. Although PCOS is associated with hyperandrogenism and infertility early in life, it is a harbinger of a lifelong condition that can lead to serious sequelae. I think this is what is becoming a very, very big concerning thing for all of us, because it definitely takes a toll on life, the quality of life later in a different age group. So diabetes mellitus, I think our country has become the diabetic capital, was always, I feel, the diabetic capital of the world. Hyperlipidemia, endometrial hyperplasia or carcinoma, central obesity, sleep apnea, and various other psychological factors, eating disorders, and so many other things which PCOS comprises of, which people are not talking of. And I think that is the reason why we need to treat PCOS, not just that a woman has to conceive or has to get regular periods or has to have this or that. I think the major, that's just the tip of the iceberg. There is a huge problem in front of us, which is lying beneath the level of the water, which I think we have to be concerned of. Why should physicians know about PCOS? The diagnosis of PCOS implies that a woman is at increased risk for the following. Number one, infertility, dysfunctional bleeding, endometrial carcinoma, obesity, obstructive sleep apnea, type 2 diabetes mellitus, dyslipidemia, hypertension, possibly cardiovascular diseases. Her sisters, daughters, and other close family relatives are also maybe at risk. So there's a genetic predisposition, and so many epigenetics, progenetics. The researchers have shown that, various genes which are responsible for various factors. She may require lifelong therapy and find that her access to healthcare coverage is limited. Epidemiology, that's another very, very important thing. Why in our country, in our side of the hello?
The interruption. Madam, please enable the editing and make it slide mode.
No, is it not coming?
No, actually, ma'am, full screen, it is not coming. Means epidemiology
It's not coming.
Is
Oh, okay. 1 second. I'll do it again. Yeah. The full screen was still not coming?
Yeah, still full screen is coming.
Ma'am, you click on enable editing first, ma'am.
Okay, because 1 second, because
Otherwise the slideshow.
now also slideshow is not there?
No, ma'am.
Okay.
Ma'am, if you can click on this next to that file home, that icons are there, ma'am, titles. There is next to animation, slideshow is there. Select on that and choose from beginning, ma'am.
Yeah, I know, but actually, 1 second.
Click on enable editing, ma'am.
Yeah. Just a second.
Or else double click on the screen, that particular slide, that can also help.
Just 1 second. Yes, I think it should be fine now. 1 second. I'll share it. Can you see the slideshow now?
Yes, ma'am. Now it's fine, ma'am.
But is it not changing? Oh God. What's the problem?
Arrow. Yes, ma'am. By arrow you can.
I think there's some technical issue this time. 1 second. I'll do it again. Now? Is it fine?
Then click on slideshow, ma'am.
I
yes,
did click. Can you see the full screen now?
Now it's okay.
Now it's okay?
Yes,
Okay, madam.
Can you see the epidemiology slide completely?
Yes, ma'am.
Yes. So sorry, everyone, for this interruption. Let's go ahead with it. So one of the most common endocrine disorders affecting women of the reproductive age group, as we all know, I feel most of them are having some features of PCOS or something of the syndrome. Seen in 8 to 11 of the reproductive age group women, most common cause of anovulatory infertility in women. Anovulatory infertility is around 70 to 80% in PCOS. Indians have amongst the highest prevalence rates in the world, 41% in the reproductive age group. So again, India is topping the chart in this thing. I don't think so. We have to be proud of it, but we have to realize what a big problem this is that we are facing, and what can we do to treat the women with PCOS, because the suffering is really bad. So coming to PCOS as an epidemic in India, as I said, I feel it's a pandemic, and India is the epicenter of it, I feel, because 41% comprising, it's quite a lot with the population of our country. So 41% prevalence, PCOD in India, 117 million patients and still rising. I think the numbers are quite more. 1 in every 5 women, but I feel 1 in every second or third woman in my OPD. So coming to the complications of PCOD, Number one being infertility. Primary infertility was reported in 50% of women. I think why infertility is coming in the number one chart, because that is when a woman starts being concerned about PCOD, and definitely it is neglected quite earlier in the adolescent period and later periods. I think that is how diabetes also is coming up in our country, because of the uncontrolled and the approach, the unaware approach towards diabetes. Primary infertility was reported in 50% of the women. Secondary infertility was reported in 25% of the women. Coming to the obstetric complications, 3 times higher risk of preeclampsia, 3 times higher risk of GDM, twofold increase in preterm deliveries, twofold increase in risk of IUGR. So coming to obstetrics part also, PCOD is also a headache for us. So cardiovascular things, twofold increase in the risk of MI, twofold increased risk of hypertension. Metabolic complications, 5 to 10-fold increase in the risk of developing type 2 diabetes mellitus. I think it's an alarming thing, and we have to be very, very careful about that, the insulin resistance in the women. Oncology complications, there is a risk of endometrial cancer. Psychological complications, 4-fold greater odds of depressive symptoms, high prevalence of anxiety disorders, reduced quality of life. So coming to the background, as we all know, Steen-IF and Leventhal-ML designated PCO as a syndrome. 80s and 90s, what did we see? There was addition of the ultrasound criteria. Around 2003, as we know, the famous Rotterdam Consensus Conference, SRM, jotted down a few points in which we can diagnose polycystic ovary. Coming to the newer approaches that we have, the International Evidence-Based Guideline for the Assessment for the Management of Polycystic Ovarian Syndrome in 2018. Coming to the definition of PCOS, there is no universally accepted definition for PCOS. As we can see, in 1990, the US NIH Consensus Conference, 2 minimal criteria were there. Menstrual irregularity due to oligo or anovulation. Second one being the clinical or biochemical hyperandrogenism like hirsutism, acne, male pattern baldness, elevated serum androgen levels. And the third one being above, not attributable to other causes. No laboratory evidence required for diagnosis, no radiological evidence required for diagnosis in the North America, ovarian appearance not pathognomic, insulin resistance not included in the diagnostic criteria, excludes women with other known causes of hyperandrogenism, diagnosis of exclusion, and clinical heterogeneity. Polycystic ovary, as we all know, it's a very simple starting refreshing our basics. It's defined as an ovary containing 12 or more follicles or 25 or more follicles with new ultrasound technology measuring 2 to 9 mm in diameter, or an ovary with a volume of more than 10 cc on ultrasonography, a single ovary meeting either or both. So we can see this, the typical picture, what we all know, pearl necklace appearance and others. Ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years, that is less than 8 years after menarche, due to high incidence of multifollicular ovaries in this life stage. Coming to the Rotterdam Consensus, as we know, it requires the presence of 2 out of the following 3 criteria: oligo and or anovulation, hyperandrogenism, clinical and or biochemical, polycystic ovaries, with the exclusion of other etiologies. Coming to the various, as we spoke about the complications, infertility, obstetrics, cardiovascular, metabolic, oncologic, psychological. In this, I want to highlight again about the metabolic with a 5 to 10-fold increase in diabetes mellitus. Infertility, as we all know. Obstetrics part also, I think when there is a PCO, we all have to be concerned about a preeclampsia, GDM, preterm deliveries, and an IUGR. As we can see, this is a summary of all the definitions that have been used again and again. We see the common factors of clinical or biochemical hyperandrogenism. Initially, we had, it has to have both. Then it came to 2 out of 3 criteria of all the 3. In this thing, coming 2006 by AES, we have hirsutism and or hyperandrogenism, and oligoanovulation and polycystic ovaries. So we had both of it. So etiopathogenesis of PCOS, I think it's very, very important to understand this thing if we have to go ahead in defining our own criteria how to diagnose PCOS in our practical field of OPD. Coming to this, We can see on the level of epigenetics, as I said, so much research is happening at the epigenetic level with the various genes being responsible for various factors responsible for polycystic ovaries. There is a wonderful saying, if anybody is hearing, to remember this thing: genes are loaded in the gun and lifestyle is the trigger. So we have to stop blaming our genes. Whatever has happened has happened. What we can do is what is important. So we do not have to let that gun being shot. So lifestyle is very, very important. So genetics and lifestyle together affecting hormonal changes exacerbated by obesity, leading to a low-grade inflammation. I think this is a condition, it's a continuous inflammatory state which the woman is going through, leading to hyperandrogenism and insulin resistance. Again, leading to all this spectrum of clinical, reproductive, metabolic. Clinically, we can see hirsutism, acne, etc. Reproductive, that is oligoanovulation, menstrual irregularity, subfertility, metabolic aspect, metabolic syndrome, IGT leading to type 2 diabetes mellitus, increased cardiovascular risk factors. Then, of course, a very comprehensive thing leading to a psychosocial issue, that is a body image, self-esteem, depression, anxiety, eating disorders, sleep disorders, and various other factors. The spectrum of PCOS from childhood to post-menopause, as we discussed here, we can see it wonderfully. The predisposing factors, genetic factors, in utero programming. I think there is, I told you as the research is going on to go to that level of it. In the childhood, can someone mute if someone is talking because there's some disturbance? Can others mute, please?
Yes, ma'am, I'm done, ma'am.
Yeah. So in the childhood pre-pubertal years, there is increased AMH levels. Coming to the pubertal age group in PCOS, what do we see? There is premature adrenarche, hyperandrogenism, increased GnRH pulse frequency, increased AMH levels or ovarian volume, hyperinsulinemia. Non-PCOS, we can see acne, increased ovarian volume, irregular menstrual cycles, insulin resistance of puberty. So this is how we have to see if we are going to have these 4 things, not necessarily it is PCOS. So we have to look for other things also. Coming to reproductive years, a decreasing androgen levels with age or a decreasing AMH ovarian reserve or AFC with age is not necessarily always PCOS. What do we look for it? We look for irregular cycles, hyperandrogenism, subfertility or infertility, increased AMH, AFC ovarian volume, glucose intolerance or insulin resistance. So these are a few differentiating factors between a PCOS and a non-PCOS. Coming to the postmenopausal years, increased prevalence of hypertension or increased triglycerides, again, which has to be differentiated from a non-PCOS, as they can also have glucose intolerance, adiposity, hypertension, and other factors. So this is the various phenotypical differences of PCOS over the different reproductive age group years before that and post that. Coming to phenotype A, B, C, D, how do we see to it? Hyperandrogenism, hirsutism, phenotype A and B, according to US NIH criteria. APCOS criteria 2006 has phenotype A, B, C. 2003 Rotterdam criteria has all the phenotypes. That is, as we can see, hyperandrogenism and hirsutism present in phenotype A. Ovulatory dysfunction is also present. Polycystic ovarian morphology is also present. Phenotype B, what do we not have? Polycystic ovarian morphology. Phenotype C, what do we not have? Ovulatory dysfunction. And for phenotype D, we don't have hyperandrogenism. So these are the various phenotypes that we have. So, and the various criteria which comprise of all of this. PCOS in adolescents. It is often diagnosed in adolescents. In utero exposure to fetal testosterone, hyperglycemia, and hyperinsulinemia depend the PCOS phenotype. The various risk factors: if there is a family history of PCOS, overweight or low birth weight, and exposure to androgens during gestation, precocious puberty or obesity, insulin resistance, diagnosis of PCOS during adolescence, requires a stricter criteria, requires unequivocal hyperandrogenism, ovulatory dysfunction for more than 2 years after menarche. Sorry. So as we've already discussed about these things, the various hormonal changes lead to increase in androgens, increase in insulin, which lead to ovarian follicles having anovulation, increased estrogen, diabetes, metabolic syndrome, the various clinical, reproductive and cardiovascular risk factors. So coming to this spectrum, what are the various peripheral damage that it causes? It increases the risk of GDM by more than 200%. Insulin resistance is present in 65 to 80% of PCOD cases. 60% of GDM patients develop type 2 diabetes mellitus. PCOD increases the risk of type 2 diabetes mellitus by 1600%. So we can see the various risk factors of GDM and type 2 diabetes mellitus. Considerable debate is on what exactly constitutes PCOS. The key biochemical features present in the vast majority of women with PCOS are insulin resistance, chronic low-grade inflammation in the PCOS. As I said, it's a continuous inflammatory state, a low inflammatory state, and insulin resistance leading to all the pathophysiological phenomena. As we can see here, what are the various things that are happening? The altered sex steroid levels, they affect the hypothalamus, leading to abnormal GnRH secretion to the pituitary, leading to increase in LH and decrease in FSH. That in turn leads to decrease in sex hormone binding globulins or an IGF-BP1, leading to insulin resistance, that is increase in insulin, increase in bioavailable estradiol, increase in bioavailable testosterone, increase in bioavailable IGF-1, affecting the ovary, in turn leading to, as we can see, affecting the skin on the adipose tissue. We can see the various changes like the acanthosis nigricans and others, and the various adrenal tissue leading to increase in DHEAS. So this is and also the LH affecting the ovary here, and the negative feedback by FSH and IGF insulin not happening. So we can see at every level, that is at the level of adrenal or the adipose tissue, skin, or the ovarian level, this is how PCOD and the various internal milieu that happens here. Development of insulin resistance. Number one, it controls the LH levels. As we spoke in form of flow chart, if we describe it or elaborate it more, it controls the LH levels. It is primarily responsible for controlling LH. It controls the androgen levels, that it mediates the androgen production in the theca cells. Insulin resistance coexists in PCOD. Women with PCOS have decreased sensitivity to circulating insulin, irrespective of weight or obesity, thus suggesting that this insulin insensitivity is intrinsic to PCOS. So coming to the inositol deficiency, it drives PCOD. This insulin resistance seems to be driven by deficiency of myoinositol and D-chiroinositol. So insulin signaling is damaged in PCOD. It is not just insulin resistance or an inositol deficiency. The insulin signaling is also damaged in PCOD. The myoinositol deficiency triggers disrupted insulin signaling. And insulin dysfunctioning disrupts the LH-FSH pathways and hyperandrogenism, as we already saw in this. So it leads to the hormonal and metabolic effect. So this is how we can see how it affects the androgen levels, the LH levels, the insulin resistance, the inositol deficiency, and how it triggers the insulin signaling, and insulin dysfunctioning in turn leads to a disrupted LH-FSH pathway. The various environmental factors leading to inositol deficiency, along with genetic factors leading to deranged insulin signaling. I think we have to keep it in our mind, printed in our mind, to know what PCOD starts from, where it comes from, how is it being triggered, leading to pituitary dysfunction, leading to enhanced ovarian androgen production, leading to development of insulin resistance, which is again a vicious circle. Clinical features, as we have already spoken so many times about it, that is irregular menses, subfertility or infertility, metabolic things being insulin resistance, obesity, increased chances of diabetes mellitus, acanthosis nigricans, as we saw how it affects the adipose tissue, and that androgenic being alopecia, hirsutism, acne. So clinical hyperinsulinemia, insulin levels may be increased in a majority of patients with PCOS. A ratio of fasting glucose to fasting insulin is a simple and effective thing. A ratio of less than 7 is suggestive of hyperinsulinemic state. So when we do a ratio of fasting glucose to the fasting insulin and we get it less than 7, it is definitely suggestive of a hyperinsulinemic state. A fasting serum insulin level more than 15, serum insulin level post 75 gram glucose of more than 25, and hyperinsulinemic status. So these are the few clinical detecting criteria for hyperinsulinemia. Infertility and the complications, as we have already discussed, multiple pregnancy. They're the most important causes of increased perinatal morbidity following fertility treatments, that is multiple pregnancies. Miscarriage, it is still debated whether women with PCOS have an increased risk of miscarriage. So that is again a debatable topic. So pregnancy-induced hypertension, preeclampsia, there is a 3 to 4-fold risk of PIH or preeclampsia and IUGR. So the first line of treatment, I think all lines of treatment that we've been speaking in so many webinars and conferences is lifestyle. It is only lifestyle and lifestyle and lifestyle, and we are talking about so many other things. And definitely they do have an effect, whether you call the inositols or you call the other factors. But I think lifestyle is the best and the first line of treatment in obese patients, but it definitely requires a lot of positivity and determination by the patient. So that is where they fail, and that is where we have to bring out other things to help the patient. In obese patients, weight loss, changes in the diet and physical activity are recommended. Just a mere 5% of weight loss does wonders for the patients. And a regular exercise of half an hour over a period of 2-3 months has brought fantastic results in patients. So it is our duty also to counsel them and motivate them for lifestyle, and simply just telling that you have to lose weight is not going to help. I think the woman definitely needs a psychosocial and a regular emotional counseling also by the doctor, because she confides in the doctor, which she cannot do it with the family members also quite often. Weight loss decreases serum insulin, androgen levels, and reduces the risk of glucose intolerance and type 2 diabetes mellitus. So it is taking care of everything at all the levels. Pharmacological interventions in the presence of insulin resistance or glucose intolerance or dyslipidemia that persist after lifestyle modification. So that is when we are going to all the drugs. So the treatment strategy, as we know, we start with lifestyle management first. Then this is how we go ahead. So the hormonal imbalance and metabolic imbalance leading to all these. We have our insulin sensitizers in the form of metformin or the various pioglitazone, rosiglitazone. Anti-androgens also can be used at times. Spironolactone, cyproterone acetate, flutamide, finasteride, various oral contraceptive pills, ovulation inducers, or clomiphene or letrozole or anastrozole. Cosmetic things we can have, women having very bad cosmetic repercussions. We can have a laser hair removal and then bariatric surgery or an acne therapy, and others coming to the laparoscopic ovarian drilling and statins for various dyslipidemia and others. So this is the current armamentarium. We can see these are the various area of things that are being used every now and then for oligo or amenorrhea, for anovulation, for acne, hirsutism, virilism, and acanthosis nigricans, for an impaired glucose tolerance or obesity. So this is how we are targeting all of them. So for an obesity, we are using mostly insulin sensitizers and LOD or statins. For an impaired glucose intolerance, we are again using insulin sensitizers alone. For acne, hirsutism, and acanthosis nigricans or a virilism, what are we using? The cosmetic things that you can see, and anti-androgens also. For an anovulation factor, what are we using? We are using LOD or LOD mostly, and ovulation inducers like clomiphene, letrozole, and others. For an oligoamenorrhea, what are we using? We are using various oral contraceptive and other hormonal preparations. Managing menstrual disturbances. If no wish to conceive, medical therapy for interruption of estrogen can be used. Non-fluctuating estradiol in the absence of progesterone cause irregular uterine bleeding, amenorrhea, infertility, and increased risk of endometrial cancer. OCPs elevate risks for CVD, dyslipidemia, and thromboembolic events. So that is also where we have to be concerned while prescribing OCPs. increased risk of type 2 diabetes mellitus with OCPs, which is dose dependent. Low dose oral contraceptive pills is therefore recommended. So it's a double-edged sword. It is definitely going to help us if there is no wish to conceive for the woman, but we have to also keep in mind the various side effects of OCPs like CVD, dyslipidemia, thromboembolism, or a type 2 diabetes mellitus. So a low dose regimen is much better. What are the various fertility treatment options coming? There is a huge debatable topic with the different things that we are using. PCOS, fertility and pregnancy. Most women with PCOS achieve the desired family size. For some of these women, medical support may be needed. So as I said, a mere reduction in weight or a lifestyle change and then proper preconceptional counseling can lead to wonders and have a wonderful family size for the woman. But there is definitely there is a percentage of women who definitely need our help. So no problems getting pregnant is about 30%, which is very good. About 70% may experience problems getting pregnant. So women with PCOS commonly have problems becoming pregnant. So the most common reason being anovulation. Healthy and active lifestyle improves our chances of becoming pregnant. As I said, that is the first line of treatment, and that is what does wonders in most of the women. And just a preconception counseling is going to help. So coming to another algorithm, which most of us are following, that is the first non-pharmacological management being lifestyle, leading to the first line pharmacological management being letrozole, clomiphene citrate, or a combination of clomiphene and metformin, or a metformin alone, or a gonadotropins. Coming to the second line pharmacological things, we have gonadotropins, and second line being surgical management being an LOD. Third line management could be more appropriate interventions, including IVF. So letrozole, clomiphene, and metformin. Letrozole should be considered first in pharmacological treatment for ovulation induction in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth rates. Where letrozole is not available or use is not permitted or cost is prohibitive, health professionals should use other ovulation induction agents. Health professionals and women should be aware that the risk of multiple pregnancy appears to be less with letrozole compared to clomiphene. As we know, the various differences between clomiphene and letrozole, the clinical pregnancy rates being better, the anti-estrogenic effects being absent in case of letrozole, and various other factors. Coming to the combination which has worked wonders, clomiphene and metformin for anovulatory infertility in obese, there is more than BMI, the BMI being more than 30, clomiphene is preferred. In obese, that is BMI more than 30, combination of clomiphene and metformin has worked wonders. So we have to selectively choose which case we are going to give letrozole and clomiphene depending upon various characteristics of the women, BMI being one of the big factors. Coming to gonadotropins, it's a second line of treatment, as we said, for ovulation induction and anovulatory infertility. It could be used in clomiphene resistant patients going up to, we've already used 150-200 clomiphene for 3 to 6 cycles, and we find there's clomiphene resistance, then we can definitely go up to gonadotropins. Gonadotropins plus metformin and clomiphene resistant patients has done wonders. Laparoscopic ovarian surgery. Laparoscopic ovarian surgery could be second-line therapy for women with PCOS who are clomiphene citrate resistant with anovulatory factors and no other infertility factors. LOD could potentially be offered as first-line treatment if laparoscopy is indicated for another reason in women with PCOS with anovulatory infertility. The risks should be explained to all women with PCOS. I think we all have a problem and itching in our fingers the moment we are doing a laparoscopy. We definitely may feel like making holes in the ovary when we see big pearly white ovaries on the lap. So where laparoscopic ovarian surgery is to be recommended, the following should be considered. The comparative cost, expertise required for use in ovulation induction. Intraoperative and postoperative risks are higher in women who are overweight and obese. There may be a small associated risk of lower ovarian reserve or loss of ovarian function. Periadnexal adhesion formation may be an associated risk. So these are the two factors which concerns people who are not in favor of LOD, that is decrease in the ovarian reserve or a decrease in image, and the various periadnexal adhesions and other complications related to any surgery. Coming to bariatric surgery for morbidly obese or obese women, I think we have to come down to an intervention, because when it becomes extremely difficult for the woman to lose weight and have an optimum BMI, it should be considered as an experimental therapy in women with PCOS for the purpose of having a healthy baby, with the risk to benefit ratios currently too uncertain to advocate this as a fertility therapy. I don't think so. We can just have it as a standard regimen. We have to weigh the risks and benefits and then choose our patients for it. Again, as we said, the bariatric surgery has its own disadvantages. That is the cause, the need for a structured weight management program involving diet, physical activity, interventions to improve psychological, musculoskeletal, and cardiovascular health. The perinatal risks like small for gestational age, premature delivery, possibly increased infant mortality, potential benefits such as reduced incidence for large for gestational age fetus and gestational diabetes. So we have risks and benefits both. Recommendations for pregnancy avoidance during periods of rapid weight loss and for at least 12 months after bariatric surgery with appropriate contraception. So at least we have to wait for a period of 12 months post bariatric surgery and then advise a woman to go ahead for conception. If pregnancy occurs, we have to monitor the pre and post-operative nutritional deficiencies, as we have a lot of electrolyte imbalance and other various factors as the sequelae of bariatric surgery, and monitoring of fetal growth during pregnancy. So the IVF recommendations, as we know, the ovarian stimulation, monitoring, follicular growth, and various aspects. So the various standard protocols over the years, over research and various articles telling us that the GnRH agonist protocol being preferred over antagonist with a reduced duration of stimulation, decreased dose in cost, and decreased OHSs. I think we have to be very, very concerned about OHSs when it comes to a PCOD patient and take a call accordingly along GnRH agonist protocol over an antagonist protocol. So the trigger with the GnRH agonist is definitely more preferred. And then freeze-all is the dictum mostly followed in most of the places. And a recombinant LH not to be used routinely with FSH. Again, we have to select our cases and decide what to do. So what are the improvement in the chances? Contraception is needed if pregnancy is not required. Discussing family planning and pregnancy health with the doctor is very important to make a plan of action so that we will be in the best health possible when trying to become pregnant. A 5 to 10% weight loss, as we said, we have to aim for a healthy weight to improve our chances of getting pregnant. If you are in the unhealthy weight range, a 5 to 10% weight loss of your total body weight will improve your chances of becoming pregnant. Consider planning your family if you wish to have children earlier than 35 years, if possible. So the faster, the better. As we all know, 25-30 being optimum, but still 30 to 35 will also do wonders. So coming to another aspect, that is inositol and PCOS, which is being popularized so much by all the companies, and I think it has also worked with our inositol inositol ratio of 40:1. Coming to the level, where does it act? At the level of the insulin signaling. So it has been seen that a deficiency of inositol affects this insulin signaling and insulin dysfunction. So insulin receptors reside in the cell membrane. When its subunit is phosphorylated by insulin, insulin receptor substrates, that is IRSS, are activated. P13K docks to the IRSS, which then leads to phosphorylation of phosphatidyl inositol, eventuating in insulin action. Insulin action. Myoinositol increases insulin sensitivity by making more phosphatidyl inositol available. As we can see, it acts on the cell membrane where we have the insulin receptors. So at the level of this cell membrane, when there is a deficiency of the inositol, we have a problem in the insulin signaling, and consequently there is a dysfunction leading to the disrupted negative feedback mechanism. Both MI, that is myoinositol, and D-inositol levels are very low in PCOS patients compared to normal subjects, as it has been seen. So normal subjects, we can see there is a huge reduction in the PCOS cases. Seeing the 24-hour urinary inositol in PCOS subjects, we can see it is very high as compared to the normal subjects. So what we have to do, we have to supplement the woman with the inositol so that the insulin signaling is proper. So MI plus DCI in the ratio of 40:1, the fertility is restored, the LH levels come down to physiological levels. It normalizes insulin signaling and glucose metabolism, leading to insulin resistance diminishes. When the insulin levels become normal, the weight loss starts. When the inflammation of ovarian theca cells come down, the androgen levels come down to normal levels, the menses become normal. Also, the LH levels coming down to normal affect the menses becoming normal. So this is how the inositol come into play. Coming to another paper where we can see the forest plot of comparison, inositol versus placebo, no treatment, standard treatment, the outcome being this. So we see that in case with supplementation with inositol and the outcome being increase in the live birth rate. So what are the various conclusions that we saw after discussing about so many factors? What are the risk factors? What is the epigenetic thing? What is the epidemiology? What is the pathophysiology? Why do we need to supplement with various factors? Which ovulation induction drugs to use? Which IVF protocol to use? And what to do? I think the first thing that we have in our mind is lifestyle, and then we go into other various aspects where the lifestyle is not working. And PCOS is a multifaceted condition, as we said, a multidisciplinary approach. It's not just the gynecologist or the obstetrician. We need a approach with the cardiologist, with the endocrinologist, with the surgeons, with various things to have a multidisciplinary approach for the subfertility and ovulation in other sequelae like cardiovascular diseases or a type 2 diabetes mellitus. A holistic care to increase success rate of fertility treatments. Lifestyle modifications like diet, exercise, and behavioral therapy are the principal management. I think we also forget the psychosocial aspect of it. It's very, very important for her to undergo counseling and to bring back her self-esteem or to have a good sleep and a good diet, and so that she can do well in her profession and other family life. Low-dose gonadotropins can be used as a first line when it comes to affordability and accessibility are not major issues, and we've already discussed how to go about it. There's an algorithm and stepwise how do we go into it. IVF ICSI indicated when previous interventions have failed in tubular occlusion or a male factor, so that is always there at the end. So concluding various things about PCOS. So we can have this thing in our mind. When we see or approach a PCOS patient, we have to prepare, communicate, overcome, and support. We have to prepare and assist the women with necessary information and resources needed to get tested. We have to communicate with her the information to the public and to women diagnosed with PCOS. We have to overcome and assist women diagnosed with PCOS to overcome the symptoms and lessen the related health risks. And we have to support the network to freely and openly discuss all aspects of PCOS. I think I have summarized all of them. It's a huge topic with many, many things happening, many new criteria coming up, many cases and research and articles coming up about PCOS. I think we have to keep on discussing about it because it's a huge challenge in our OPD and among the female population. As we said, we have to prepare, communicate, overcome, and support women with PCOS. Thank you so much.
Thank you very much, madam, for this nice discussion on this emerging topic, PCOS. So just give me 1 minute time to collect the question, if any, in our dashboard. Madam, first question is, if a patient can significantly reduce her weight with the lifestyle modification, is there any necessary to give some drugs to combat this problem?
No, I think lifestyle is the first line of management. As we said, the 30 to 40% of the women with PCOS conceive after a reduction in weight from merely just 5% of weight loss has done wonders. So there is no need to supplement anything else if the woman is conceiving properly and with proper, evaluation throughout the pregnancy to rule out PIH or a preeclampsia or an IUGR. We can definitely, not supplement her with anything.
Okay, madam. Thank you. And ma'am, is there any grades of PCOS in terms of the severity of the PCOS on the basis of which you can optimize the treatment protocol for a particular patient?
No, I don't think so. It depends upon what the woman, which age group the woman is in. Whether she's in adolescent age group, she's only concerned about her irregularity of the periods, then we can just think of making her periods regular to combat her anovulation. Whether she's in her fertile period, so we have to think about the ovulation induction and other things. So I don't think so. Grade, it's about the what is the phenotype of the PCOS. As we discussed, the phenotype A, B, C, D, what are the various factors in it? We are concerned about fertility, or we are concerned about insulin resistance. If she's a postmenopausal age group, we are more concerned about the cardiovascular sequelae or a type 2 diabetes mellitus. So I think we have to target what the woman is suffering from, which age group she's in, what we have to treat her, whether we are treating her fertility or her dyslipidemia or a cardiac issue or a diabetic issue, or we are treating her adolescent irregularity of periods. So I don't think so we can grade it in any way.
Okay. And another question, ma'am, as it's an inflammatory disorder, so any kind of infection can lead to PCOS? Any kind of vaginal infection or some other infections can lead to PCOS? Is there any information?
See, but it's a low inflammatory state, as we all know. There are many researches happening at the epigenetic levels, but
Yes.
significantly, I don't think so any infection has been proven leading to PCOS. So I think
Okay.
it's the various factors which are responsible are the lifestyle and the metabolic things that are happening at the hormonal level, at the level of the adrenals, or the level of the ovary, or the level of the skin. And I don't think so any infection as such leads to a polycystic change
Sure.
in the ovary.
Okay, ma'am. And ma'am, the last question is how you recommend this melatonin? Melatonin, we are now seeing that doctors are using. So what is your
Yeah.
opinion on that?
Yeah, it is definitely used. I think so many things are being used for PCOS nowadays. I find people prescribing some green tea extracts, Chinese things, and so many herbs and medicines.
Yes.
I myself have no, much knowledge and much success with melatonin or something. I think inositols have done quite well with the experience, but I don't think I don't know how much melatonin is going to help for PCOS. But
Yeah.
there are various studies which have proved many things.
Yeah. Thank you. So thank you very much, madam. I could not find any other question in our data. So
I
if you
think,
allow me.
I think it will be on YouTube. I think people are going to see it later. And if at all they post any questions, I'll be
Yes,
answering
yes,
it.
obviously we will get back to you, ma'am. So
Yeah.
thank you very much, ma'am, for your valuable time and this nice discussion. So in
Thank you
future
so
also,
much.
we will look forward for some valuable session with you, ma'am, in an emerging topic also. So thank
Yes,
you very
thank you
much,
so
ma'am.
much.
Have a good day, ma'am.
Thank you. Thank you so much.